You know that image, right? A beautiful horse, looking strong, healthy, just majestic.
Yeah, absolutely. It's why we're drawn to them.
But then sometimes you see that shift. Maybe they're just looking back at their flank, seem a bit off,
Mm-hmm.
and you notice their belly. It looks bigger. Swollen, maybe?
And that specific sign, that visible change in the abdomen size or shape, well, that's something that always catches your eye. It's definitely a worry.
It's never just normal, is it?
No, definitely not. It signals something pretty significant is going on inside.
And that's exactly what we're digging into today. We've gone through quite a stack of expert sources. Think veterinary texts, specialized guides, all focused on equine abdominal distension.
Right. We're looking at the causes, how vets figure it out, the treatments,
Yeah.
the whole picture.
Our goal really is to boil down all that complex medical info,
Yeah.
make it clear and useful for you.
Exactly. Cut through the jargon, pull out the key takeaways about what this distension actually means, why it's often so urgent in horses, and how vets tackle it.
Yeah.
Because it can be potentially life-threatening.
We'll get into the horse's unique anatomy, why they're kind of set up for certain problems.
Yeah, that's crucial context.
And the sheer variety of reasons why their belly might swell.
Yeah.
It's definitely not just one simple thing.
Got it all.
Then we'll look at the detective work vets do and, what can actually be done. It's a real journey into understanding a critical condition.
And this is really for you listening, whether you own horses, ride, or just love them. Knowing what this sign means and, importantly, why getting help fast is so vital, that can make a huge difference.
Okay, let's jump in. So what exactly is abdominal distension in a horse? Laying the groundwork.
So basically, it's when you can visibly see the abdomen get bigger. It's an abnormal enlargement, changing the horse's usual shape or contour.
So it's not just like a horse carrying a bit of extra weight.
No, it's a distinct change from their normal shape. And, it can vary a lot. Sometimes it's subtle. Maybe the flanks just look a bit full. The horse seems a little uncomfortable.
Okay.
Or it can be really dramatic, what people might call bloat, where the abdomen is massively swollen.
And when it gets that severe, you mentioned it can affect other things, breathing, circulation.
Oh, absolutely. That internal pressure can really push on the diaphragm, making it hard for them to breathe properly. It can also squeeze major blood vessels, messing with blood flow back to the heart. That can lead to shock.
People often connect it with colic, that general term for belly pain. But distension isn't always just about gut pain itself, is it?
That's a really important point. Yes, it's very often linked with colic signs, but they aren't the same thing. Sometimes the distension is the main sign, or it might come from something outside the digestive tract entirely.
Like what?
Maybe fluid building up in the abdomen, or even a large tumor. The key thing, the real takeaway here, is that significant abdominal distension, whatever the cause, is always a red flag. It needs checking out fast.
Got it. Always serious. So to understand why it's such a big deal for horses specifically, we need to talk about their insides, right? Their anatomy.
Exactly. Their digestive system is incredible for what they do grazing constantly.
Yeah.
But it definitely has some, let's say, design quirks that cause problems.
Okay, like what? Start with the stomach.
Yeah, the stomach. First off, it's relatively small for their size, only holds about, 8 to 15 liters.
It seems tiny for a big animal.
It really is. And here's the critical bit. The valve, where the esophagus joins the stomach. It's basically a one-way street. Horses, they really can't vomit effectively or even burp properly to relieve pressure.
So if gas or fluid builds up in that little stomach.
There's nowhere for it to go easily. It can't really go back up. And if something's blocking the way out, well, the pressure builds incredibly fast.
Putting the stomach wall at risk.
Precisely. There's a serious risk of the stomach actually rupturing. And that's almost always catastrophic. Fatal.
Wow. Okay, stomach small, one-way valve. What's next?
Then you've got the small intestine. It's incredibly long, around 70 feet.
70 feet. That's hard to picture packed in there.
It is. And it's quite mobile, not tightly fixed in place. All that length and mobility makes it prone to, getting tangled or twisted or just blocked.
Like a kink in a hose.
Sort of, yeah. If you get a blockage there, everything upstream fluid, gas starts backing up. And where does it back up to eventually?
The stomach.
Right back to that small stomach, causing that dangerous secondary gastric distension, and you might see reflux fluid coming back out the nose.
Okay, small stomach, super long small intestine. What about the large intestine? That's huge in horses, right?
Massive. The large colon and the cecum, they're like huge fermentation vats. And the large colon in particular is mostly, free-floating. It's not really tacked down inside.
Which means it can move around.
A lot. It can easily shift out of its normal position, we call those displacements, or, much worse, it can twist completely on itself. That's a torsion or a volvulus.
And a twist sounds really bad.
A large colon volvulus is one of the most severe surgical emergencies. When it twists, it cuts off its own blood supply. The tissue starts to die very quickly, gas gets trapped, and it causes immense pain. Often happens suddenly, particularly in mares after foaling.
So displacements and twists are major risks because it's so mobile.
Exactly. Like a common displacement is the left dorsal displacement, where part of the colon gets hooked over a little ligament between the spleen and the kidney.
So summing up the anatomy risks, the one-way stomach, the really long, mobile small intestine, and this massive, unanchored large intestine. These create spots where things can easily get blocked, trapped, or twisted.
That's the heart of it. Their gut is perfectly designed for grazing, but these features make them uniquely vulnerable to conditions that cause distension and have very serious consequences.
Okay, that anatomy lesson really sets the stage. Before we list all the potential causes, let's quickly paint the picture of what this looks like clinically. What signs might you actually see, besides just the belly getting bigger?
Good idea, because it's usually a collection of signs. The distension itself, as we said, might be all over, kind of a rounded look, or it might bulge more on one side, say the right flank, if the cecum's involved.
Pain is almost always part of it.
Almost always. The colic signs,
Yeah,
and they can range hugely.
from just seeming a bit uncomfortable.
Yeah, like watching their flank, curling their lip, maybe a bit of pawing, to really severe violent pain, rolling uncontrollably, thrashing, sweating, potentially injuring themselves.
What about manure?
Yeah, fecal output is a big clue. You might see fewer droppings or none at all if there's a blockage like an impaction. Or conversely, you could see diarrhea, sometimes really profuse if there's severe gut inflammation like colitis.
And their general state, appetite, drinking.
Usually off, they'll likely lose their appetite, stop drinking. They often look depressed, lethargic, and their vital signs give critical information.
Like heart rate?
Heart rate is usually elevated, sometimes dramatically, due to pain or developing shock. Breathing might be fast and shallow, especially if the distension is pressing on the lungs.
Gums.
Checking the gums is vital. Are they pale or a muddy, toxic color? Is the capillary refill time slow? These are signs of poor circulation, shock. And sometimes, as we mentioned, you might even see fluids spontaneously coming out of their nostrils, gastric reflux.
So it's that whole cluster. The visible swelling, the pain behaviors, changes in manure, and those systemic signs like high heart rate and bad gums. That's the alarm bell?
That's the picture that says call the vet now.
Okay, now let's unpack the potential culprits. Our sources break this down really well by what is actually causing the swelling inside. Makes sense.
Right. Broadly, the distension comes from too much gas, too much fluid, a buildup of solid stuff like feed or manure, or a physical mass or enlarged organ.
Gas seems like the most obvious one, the bloat idea.
Yeah, and simple gas colic or tympanic colic is pretty common. It often happens if fermentation in the hindgut goes into overdrive, maybe a sudden feed change, too much rich grass, stress, or sometimes the gut just slows down and traps normal gas.
And how does that look?
Often it's a more diffuse distension. The whole belly looks kind of rounded, maybe tight like a drum.
But gas can be trapped much more severely.
Oh, definitely. If the colon displaces or twists, like we discussed, left dorsal displacement, right dorsal displacement, or the dreaded large colon volvulus, it traps gas and fluid behind the blockage or twist.
And the volvulus is the worst case gas scenario.
By far. That twist strangulates the bowel, cuts off blood supply, leads to massive, often uneven gas distension and extreme acute pain. Cecal tympany, which is just gas building up in the cecum, usually causes swelling more localized to the right flank.
Can problems in the small intestine cause gas buildup too?
Yes. Any blockage in the small intestine, whether it's a physical obstruction like an impaction or a tumor, or a functional problem like severe enteritis, where the gut just stops moving, it causes gas and fluid to back up proximal to or upstream from the blockage.
Leading to that secondary stomach distension again.
Exactly. You get small intestinal loops distended with gas and fluid, and eventually it backs right up into the stomach. Very dangerous.
Okay, so gas, simple fermentation, or trapped by displacements, twists, blockages.
Got it.
What about fluid? How does that cause distension?
Well, there are a couple of main ways. First, you can get fluid accumulating outside the intestines, just free in the abdominal cavity. That's called ascites, or peritoneal effusion.
What causes fluid to build up around the gut like that?
Lots of things. Widespread inflammation or infection in the abdomen, peritonitis. Maybe really low protein levels in the blood, which can happen with severe gut disease, liver failure, kidney disease, sometimes right-sided heart failure, even certain types of cancer or internal bleeding.
And does that look different from gas bloat?
Usually, yes. Ascites tends to give a more widespread, heavy, pot-bellied look. Sometimes you can even feel a fluid wave if you gently rock the horse's belly. It feels, well, fluidy rather than tight like a drum.
Okay, so that's fluid around the gut. What about fluid in the gut?
Right. You see massive amounts of fluid build up inside the intestinal lumen with severe inflammatory conditions like enteritis or colitis, perhaps from infections like salmonella or clostridium.
How does that happen?
The gut lining gets so inflamed it basically starts leaking fluid, hypersecreting, and it can't absorb properly. So you get large volumes of fluid accumulating within the bowel loops themselves. This often goes along with terrible diarrhea, and the abdomen might feel kind of sloshy.
Internal bleeding would count as fluid too, right? Hemoperitoneum?
Yes, exactly. Blood loss into the abdominal cavity from a ruptured vessel or a tear in an organ like the spleen or liver, maybe after a trauma or Foley complication.
Any other fluid causes?
Yeah. Uroperitoneum, that's urine leaking into the abdomen, usually from a ruptured bladder, more common in males, especially foals. And in pregnant mares, you can get hydrops, excessive fluid in the fetal membranes, or pyometra, which is pus building up in the uterus. Both can cause pretty dramatic distension.
Okay, gas and various fluids. What about solid blockages? Impactions?
Very common cause of colic and distension. A large colon impaction is probably the classic one. Usually happens at the pelvic flexure, a narrow hairpin turn in the colon.
What causes the blockage?
It's usually a buildup of dry, firm feet material, sometimes mixed with sand if they're grazing sandy areas. Risk factors are things like dehydration, not enough exercise, sudden change from lush grass to dry hay, poor teeth, meaning they can't chew properly.
And how would that feel to a vet doing a rectal exam?
Typically feels like a firm, kind of doughy mass in the back left part of the abdomen. And yes, an impaction can definitely cause gas to build up behind it, adding to the distension.
Are there other types of impactions?
Sure, you can get small colon impactions further down the tract, usually less dramatic, and ileal impactions right at the end of the small intestine. Those are often linked with certain haze, like coastal Bermuda or heavy tapeworm burdens. They cause small intestinal distension and, again, that risky gastric reflux.
Right. Okay, last category. Distension from a physical mass or an enlarged organ.
Yeah. Sometimes the swelling is literally due to something large growing inside. Big tumors, lymphoma is a common one, but others too. Large abscesses or granulomas, which are inflammatory masses.
And pregnancy, obviously.
Of course, normal late-term pregnancy causes significant expected enlargement, and sometimes severe obesity can look like distension, but it's just fat, not the same underlying issue.
Could an organ itself get bigger?
Yes, things like splenomegaly and enlarged spleen can contribute. And finally, sometimes the problem isn't inside the cavity, but the wall itself. A large hernia where intestines bulge out, or a ruptured prepubic tendon.
What's that?
It's a strong tendon that supports the abdominal floor, especially important in heavily pregnant mares. If it tears, the belly can drop dramatically, causing severe ventral swelling, often unevenly.
Wow. Okay, that list is extensive. Gas, fluid, solids, tissue masses. Given all those possibilities and how serious you said this can be, how on earth does a veterinarian figure out which one it is? Seems like a huge puzzle.
It really is, and it requires a very methodical, systematic approach. You can't just guess. It starts with getting a really thorough history.
From the owner or handler.
Exactly. The vet needs the horse's signalment age, breed, sex, because some conditions are more common in certain groups. You know, older horses might get strangulating lipomas, postpartum mares are high risk for colon torsion.
Little clues like that.
Huge clues. Then, the story of the episode itself. When did it start? Was it sudden, severe, or gradual? Is it getting worse, and how quickly? Rapid worsening often points to something serious, like a twist or strangulation.
What else in the history?
Diet is huge. Any changes recently? What's the hay like? Grain? Water intake, has it been normal? Access to sand? Deworming history? Has the horse had colic before? And critically, what's the manure situation been? Normal, reduced, absent, diarrhea?
Okay, history first, then the hands-on exam.
Right. Observing the horse first, their pain level, posture where the distension seems worst. Then the vital signs: heart rate, respiratory rate, temperature, gum color, capillary refill time. Listening carefully to the abdomen with a stethoscope.
What are you listening for?
Gut sounds. Are they normal, increased, decreased, or totally absent? Sometimes you can hear specific high-pitched pings which strongly suggest gas trapped in a distended loop of bowel. Feeling the outside of the abdomen can sometimes reveal tense areas or firmness.
And then those two really key procedures you mentioned earlier.
Absolutely vital. Nasogastric intubation and rectal palpation. Passing that tube down into the stomach is non-negotiable.
Why is this so important?
2 reasons. First, diagnostic. If you get a large amount of fluid back, say, more than 2 liters in an adult horse or a big rush of gas, that tells you immediately there's a significant problem in the stomach or small intestine causing backup. Second, it's therapeutic. Relieving that pressure can be life-saving, preventing gastric rupture.
Makes sense. And the rectal exam? Performed by the vet, obviously.
Yes, requires skill and experience. It's indispensable, even though you can only feel the back part of the abdomen. The vet can often identify impactions, feeling that doughy mass. They can feel distended loops of bowel, sometimes identify displacements by feeling structures in the wrong place. They can assess for signs of strangulation, like thickened bowel wall or tight bands. It provides critical information, especially about the large intestine.
Okay. History, physical, tube, rectal. What about lab tests? Blood work?
Standard procedure. A basic blood count tells us about hydration, the packed cell volume or PCV, and infection or inflammation via the white blood cell count. Blood chemistry looks at electrolytes, kidney function, liver enzymes, and crucially, lactate levels.
Lactate. Why is that important?
Lactate builds up in tissues that aren't getting enough oxygen. A high blood lactate level is a strong indicator of poor perfusion, like in shock, or intestinal strangulation where the blood supply is cut off. It's a key prognostic indicator.
In the belly tap. Abdominocentesis.
Right. Taking a small sample of the fluid that's normally present in the abdominal cavity, analyzing that fluid can be incredibly informative.
What are you looking for in that fluid?
Normal peritoneal fluid is clear, pale yellow, with very few cells and low protein. If it comes back cloudy, reddish, full of inflammatory cells, high in protein, or especially high in lactate compared to the blood lactate, that points towards serious problems.
Like strangulation or infection.
Exactly. Strangulation often causes reddish fluid with high protein and lactate. Peritonitis causes cloudy fluid with high cells and in protein. Finding feed material means a rupture. We also check creatinine levels. If they're much higher in the belly fluid than in blood, it means urine is leaking in from a ruptured bladder.
So tests help narrow it down. What about imaging? Ultrasound? X-rays?
Abdominal ultrasound is hugely valuable, especially nowadays. The vet can directly visualize the intestines. Look at wall thickness. Is it thickened due to inflammation? Is the gut moving? Is there excess fluid inside or outside the bowel? Are loops of bowel in abnormal locations? Can we see masses or abscesses?
Sounds very useful. X-rays.
X-rays or radiographs are most useful in foals because they're smaller and easier to image. In adult horses, they're mainly used to look for dense things like intestinal stones and pteroliths, or large amounts of sand, usually visible in the bottom part of the abdomen.
So you gather all these pieces, the history, the exam findings, the tube results, rectal feel, lab work, maybe ultrasound, and try to put together the most likely diagnosis.
That's the process. It's about building a case, ruling things out, identifying the most probable cause to guide treatment.
Which brings us to treatment. Once the vet has a good idea what's going on, what's the plan?
Well, it's always tailored to the specific cause, but the absolute first steps are stabilizing the horse and controlling pain.
Pain relief is immediate.
Yes. Using drugs like flunixin meglumine or banamine, which is an NSAID good for visceral pain and also helps fight endotoxemia. Sometimes stronger drugs like alpha-2 sedatives, such as xylazine or ditomidine, or even opioids if the pain is severe.
The nasogastric tube again, if needed.
Absolutely. If there's evidence of gastric distension or reflux, keeping that tube in place or passing it repeatedly to drain the stomach is critical. And fluid therapy is almost always needed.
IV fluids.
Yes. Intravenous fluids are essential to correct dehydration, support circulation, and correct electrolyte imbalances. Horses with severe colic can need huge volumes. Sometimes, if there's no reflux, fluids can also be given carefully via the nasogastric tube.
Okay, stabilization and pain control first. Then specific treatments depend on the cause.
Exactly. If it's a simple gas colic, maybe just pain meds, possibly an antispasmodic like Buscopan, and time. For impactions, the focus is on rehydration, 5E fluids are key, and laxatives given via the tube.
Like mineral oil.
Mineral oil is common. Magnesium sulfate, Epsom salts, draws water into the gut. Psyllium is used specifically for sand impactions. Gentle walking can sometimes help too.
What about for inflammation like colitis?
That requires really aggressive supportive care, massive amounts of IV fluids, electrolytes, often plasma transfusions if they're losing a lot of protein. Managing the endotoxemia is critical using NSAIDs, maybe polymyxin B, to bind toxins, things like biosponge, sometimes antibiotics, but used judiciously.
And then surgery. When is that needed?
Recognizing the need for surgery and acting quickly is paramount for certain conditions. Exploratory laparotomy, opening the abdomen surgically, usually under general anesthesia, is often the only way to definitively diagnose and fix the problem.
Or what are the definite surgical cases?
Any suspected strangulating lesion where the blood supply is cut off, like a volvulus or a strangulating lipoma, needs surgery immediately. Severe large colon displacements that aren't resolving. Small intestinal obstructions like blockages from tumors or foreign bodies, or ileal impactions that don't respond to medical treatment. Even severe gastric distension that seems likely to rupture might need surgical intervention, though it's high risk. And large colon impactions that just won't budge after, say, 24-48 hours of intensive medical therapy might need surgery to be physically removed.
Is there anything less invasive than full surgery sometimes?
Occasionally. For severe cecal tympany, just gas in the cecum, a vet might carefully insert a large needle through the flank into the cecum to release the gas. It's called trocherization. It can be life-saving, but carries risks like infection.
What about rolling?
For some specific displacements, like the left dorsal displacement, sometimes rolling the horse carefully under anesthesia can encourage the colon to flop back into place, often done after giving a drug to shrink the spleen.
And general care during all this?
Continuous monitoring is key, keeping the horse calm, usually confined, withholding feed while they're painful or obstructed, and, crucially, referring the horse to a specialized hospital quickly if surgery or intensive care is likely needed.
It's a lot. So after all that, what's the outlook? What's the prognosis?
It varies massively, hugely dependent on the cause, how bad it is, and maybe most importantly, how fast it was diagnosed and treated.
What generally has a good outlook?
Simple gas colics, most pelvic flexure impactions that respond well to fluids and laxatives. Those usually have a good prognosis. The horse gets better with medical management.
And the surgical cases? More guarded?
Often, yes. Many large colon displacements, if caught and corrected quickly, can have a fair to good prognosis. Small intestinal issues, especially strangulating worms, are more serious, guarded to poor. Really depends how much gut is damaged and how quickly they get to surgery.
What has a poor prognosis?
Large colon volvulus, unfortunately, often carries a poor prognosis because the damage happens so fast. Severe strangulating lesions found late. Gastric rupture is almost always fatal. And severe colitis can be very tough due to complications like shock, laminitis, and protein loss.
It really sounds like time is the absolute enemy here.
It is. Early recognition, prompt veterinary attention, accurate diagnosis, and decisive treatment, whether medical or surgical, are the keys to improving the odds. Delay is often the difference between life and death.
Which leads perfectly into the final crucial piece: prevention. What can we do as owners or caretakers to try and stop these things from happening in the first place?
That's where we can have the most impact. It's all about managing the risk factors we know about. Diet is number one.
Consistency.
Consistency is king.
Yeah.
Any changes to feed hay type, grain amount, even pasture access must be done gradually. We're talking over 7 to 14 days, ideally. And prioritize forage.
Lots of hay.
Plenty of good quality forage. Horses are designed to eat fiber almost constantly. Aim for at least 1.5%, ideally 2%, of their body weight in forage per day. If you feed grain or concentrates, keep meals small and frequent based on their actual energy needs, not just habit.
And water. You mentioned dehydration for impactions.
Absolutely non-negotiable. Constant access to fresh, clean water all year round. In winter, making sure it's not frozen, maybe even warming it slightly, can encourage drinking.
What about exercise?
Consistent exercise helps keep the gut moving. Avoid sudden, prolonged periods of stall rest if possible, or manage that transition carefully. Regular turnout is generally beneficial.
And teeth?
Crucial. Regular dental exams and floating at least once a year ensure they can chew properly, breaking down feed effectively. That's the first step of digestion.
The parasite control.
Yes. Following a vet-recommended deworming strategy is important, particularly targeting things like tapeworms, which are linked to ileal impactions.
What about sand?
If you live in a sandy area, try hard to feed off the ground. Use feeders, mats. Some people feed psyllium periodically, which can help carry sand out of the gut.
Anything else? Stress.
Yeah, trying to minimize major stressors can help. Big changes in routine, frequent intense travel or competition, social upheaval, these things can impact gut function.
And being aware of individual horse risks, like cribbing.
Exactly. Cribbers might be at higher risk for certain types of colic. Horses with a history of ulcers need careful management too. Prevention is really about attention to all these details of good husbandry.
Okay, so let's try and pull this all together.
Yeah.
We've gone through the horse's unique anatomy, those vulnerabilities like the one-way stomach and mobile colon. We explored the huge range of things that can cause that belly to swell: gas, fluid, impactions, masses,
It's a surprisingly long list.
and the really serious, potentially fatal consequences that can happen quickly, like shock, gut dying off, rupture.
The stakes are high.
We walk through how vets approach it systematically. The history, the exam, the vital nasogastric tube and rectal exam, labs, imaging.
That diagnostic process is key.
Discuss treatments, from fluids and meds to the critical decision for surgery, and emphasized how prognosis hinges so much on speed.
Timeliness is everything.
And finally, how good management, diet, water, exercise, dental, parasites forms the foundation of prevention.
Absolutely. That preventative care is paramount.
What really strikes me listening back to all this is just how vulnerable they are because of that anatomy, that inability to vomit, the sheer mobility of that large intestine. It means just a little bellyache can escalate incredibly fast.
It really does. It underscores why you can never be complacent about colic signs or abdominal distension in a horse. Understanding that potential for rapid deterioration is so important.
So for you listening, knowing these possibilities, recognizing those early signs, even subtle ones, and understanding why getting your vet involved immediately is non-negotiable, that's incredibly valuable knowledge. You're definitely better equipped now if you ever face this situation.
Hopefully, yes. It just highlights that delicate balance in keeping them healthy.
It really does. Think about how something seemingly small, a sudden switch in hay bales, maybe the water trough freezing over for half a day, how that can potentially cascade because of their specific digestive setup into a full-blown emergency needing major surgery.
It's a stark reminder of how interconnected their management and their physiology are.
It really makes you appreciate that preventative care isn't just ticking boxes, it's actively mitigating those inherent risks. So maybe a final thought for you to ponder, based on everything we've discussed, was one small practical preventative step related to feed, water, exercise, or just observation that you could focus on improving or double-checking today for the horses you care about.